Hello, everybody, and welcome to our module on lysosomal storage diseases. Let's start by reviewing the function of lysosomes. Lysosomes are membrane-bound organelles found inside of cells, and they contain numerous enzymes that break down lots of different biological structures. They can break down proteins and nucleic acids, carbohydrates, lipids, and many, many other things. Their job is to digest obsolete components of the cell. I think of them as the vacuum cleaner of the cell, picking up all the used and unnecessary components inside of the cell. A lysosomal storage disease occurs when a child is born with the absence of one of the lysosomal enzymes, and as a result, that child will be unable to break down certain complex molecules. As a result, those molecules will accumulate, and this leads to disease. All of these diseases are very rare. Most of them are autosomal recessive, and most of them have no treatment or cure. What makes them so hard for step one is that the enzymes involved are usually very unusual. You're not going to be familiar with them, and you're going to have to learn the names of these unusual enzymes and the complex structures that they metabolize. Before we talk about specific lysosomal storage diseases, let's talk about some of the structures that accumulate in children born with these conditions. Most of the lysosomal storage diseases involve abnormal processing of sphingolipids. So let's talk about what a sphingolipid is. Well, all sphingolipids contain a structure called sphingosine. That's where they get their name from. Sphingosine is a long-chain amino alcohol. This is the structure of sphingosine on the screen. You can see that most of it is carbon and hydrogens, much like a fatty acid. However, where a fatty acid would contain a COOH group, sphingosine contains two hydroxyl groups and a nitrogen group. And all sphingolipids contain the structure of sphingosine. Now, if you add a fatty acid to the NH2 group on sphingosine, this NH2 group here, you will get a structure called a ceramide. This is an example of a ceramide on the screen. You can see that the top portion is sphingosine and the bottom portion is a fatty acid that has been added. And most of the molecules that accumulate in lysosomal storage disorders are ceramide derivatives. They all contain sphingosine, and they are all examples of sphingolipids. If you modify a ceramide molecule by adding a head group to the hydroxyl on ceramide, you can get many other structures like glycosphingolipids and sulfatides, and all of these are the sphingolipids that we'll be talking about in this module that accumulate in lysosomal storage diseases. These complex molecules are very important for nerve tissue, so as we will see, children born with lysosomal storage diseases often have central nervous system problems. In addition, when you cannot break down these large complex molecules, they often accumulate in the liver and spleen. And as we will see, hepatosplenomegaly is common to many of the lysosomal storage diseases. The first lysosomal storage disease we'll discuss involves abnormal metabolism of ceramide trihexoside. This also goes by the name globotriacylceramide, or GB3. And this structure contains a ceramide molecule, like I showed you on the last screen, connected to a 3-sugar head group. There's a ceramide connected to glucose and then 2 galactose molecules. And this structure is broken down inside of lysosomes by an enzyme called alpha-galactosidase A. And children who are born with a deficiency of alpha-galactosidase A have a condition called Fabry's disease, where they accumulate ceramide trihexoside. Fabry's disease has a couple of unique characteristics among the lysosomal storage diseases. First of all, it's X-linked recessive. Most of the lysosomal storage diseases are autosomal recessive. In addition, the symptoms are slowly progressive. They begin in childhood and progress to early adulthood. Fabry's disease is a condition that you can live with well into adulthood. People live into their 30s, 40s, and even 50s. That makes it very different from some of the other lysosomal storage diseases we'll talk about, where children usually die before they're a few years old. The biggest problem for people living with Fabry's disease is pain. They develop a neuropathy that classically involves the limbs, especially the hands and feet. This can be a very painful condition and can be very difficult to treat. On their skin, they develop angiokeratomas. These are small red to purple raised spots that come from dilated surface capillaries. This is a picture of angiokeratomas on the trunk shown on the screen here. And then finally, people with Fabry's disease have decreased sweat. The symptoms on the last slide are uncomfortable but are usually not life-threatening. But what can be life-threatening about Fabry's disease is when it begins to involve the kidneys and the heart. In the kidneys, patients with Fabry's disease can develop proteinuria, and this can ultimately lead to renal failure, and they can end up on dialysis. In the heart, these patients can develop left ventricular hypertrophy, and this can ultimately lead to heart failure. In addition to the kidneys and the heart, a classic problem among Fabry's disease patients is TIA or stroke, especially at an early age. The sphingolipids can accumulate in vascular endothelial cells, and this can narrow or obstruct arteries, and this can lead to strokes. Because the symptoms of Fabry's are subtle in the beginning, like pain in the hands or a skin rash, this condition is often misdiagnosed initially. And people with Fabry's often go for many years until they find a clinician who makes the diagnosis. And another important thing to know about Fabry's disease is that there is an enzyme replacement therapy that's available. There are synthetic recombinant galactosidase enzymes that these patients can take as medical therapy, and this seems to improve some of the symptoms of Fabry's disease, especially the pain in the hands and feet. It's less clear whether it reduces the long-term mortality from things like heart failure and kidney failure and stroke. So the classic case of Fabry's disease to know for your boards is a child or maybe a young adult with pain in the hands and feet, a lack of sweat, and those skin rash findings I showed you 2 slides ago. This is a very unusual constellation of symptoms. You shouldn't confuse this with any other lysosomal storage disease. Only Fabry's disease looks like this, and it's caused by a deficiency of alpha-galactosidase A and accumulation of ceramide trihexoside. The next sphingolipid we'll discuss is called glucocerebroside, and the structure of this molecule consists of ceramide with a glucose head group. If you look at the structure on the bottom of the screen here, this is a glucose head group attached to a ceramide molecule. The enzyme that breaks down glucocerebroside is appropriately named glucocerebrosidase, and if you are deficient in this enzyme, you have a condition called Gaucher's disease. Gaucher's disease is the most common lysosomal storage disease. It's still very rare, but among all the lysosomal storage diseases, Gaucher's is the most common. It's an autosomal recessive condition, and it is more common among people who are of Ashkenazi Jewish descent. The Ashkenazi Jewish population comes from Europe and places like Germany and France, and people who descend from that population have an increased likelihood of developing Gaucher's disease. The main organ systems affected in Gaucher's disease are the liver, spleen, and bones. You can see hepatosplenomegaly, and especially among children with the condition, an enlarged spleen is the most commonly detected initial sign. Children have small abdomens, and it's often easy to detect an enlarged spleen when they develop Gaucher's disease. The bones are also affected. First of all, the marrow can be affected. Children with Gaucher's disease often have anemia. They can also develop thrombocytopenia, and rarely they get leukopenia as well. The way this often presents, especially in a board question, is as easy bruising from the low platelets. In addition, the bones can be affected at the joints. Avascular necrosis, which is ischemia of the joints, can develop. This is because enlarged macrophages full of sphingolipids can obstruct those vessels supplying blood to those joints, and this can lead to joint pain and even joint collapse. Rarely there are CNS manifestations. This does not occur in the most common form of Gaucher's disease, but there are 2 less common forms where neuropathic disease develops. This includes gaze palsy and dementia and ataxia, and these rare forms with neurologic involvement tend to be much more deadly. This is a picture of a Gaucher cell. It's a macrophage that is filled with sphingolipids. It's described as having an appearance that looks like crinkled paper, and the reason I bolded the word macrophage is because sometimes the board simply wants you to know which types of cells are involved, and you should remember that macrophages become abnormal in Gaucher's disease, and that can help you remember that the liver and spleen are often affected because that's where macrophages tend to live. You can see cells that look somewhat like this in certain forms of leukemia, especially chronic myeloid leukemia, and those cells are called pseudo-Gaucher cells. I mentioned before that the bones can be involved in Gaucher's disease, but I want to mention now that children with this condition often develop what's called a bone crisis. This is severe bone pain due to infarction and ischemia, usually of the joint. It results from the infiltration of enlarged Gaucher cells, those big macrophages, into the intramedullary space. It results in intense pain, often with fever, and it can look a lot like sickle cell anemia, and that's because the pathophysiology is somewhat similar. It's abnormal cells that are clogging up the vasculature and resulting in bone ischemia. The most common form of Gaucher's disease is called type 1. This form of the disease presents anywhere from childhood to young adulthood, and importantly, it has minimal or no CNS features. As I told you a few slides ago, some of the more serious variants of Gaucher's disease have central nervous system involvement, but not the most common form, type 1. People with this form of the disease have enlarged livers and spleens. They can have bruising and anemia from the bone marrow involvement, and they can have joint problems. Importantly, these people can potentially live a normal lifespan, and that's because there is enzyme replacement therapy that's available. Certain drug companies manufacture synthetic recombinant DNA versions of the missing enzyme glucocerebrosidase. As a result, people with this condition can take this replacement enzyme and they can potentially have relief from many of the symptoms and lead a normal lifespan. The more rare forms have central nervous system involvement. So the type 2 form, which is sometimes called the infantile form, presents in infancy with marked CNS symptoms, and these children usually die before they're 2 years old. There's also a very rare type 3, which has childhood onset, results in progressive dementia and a shortened lifespan. You're much less likely to be asked about these two types on step 1. They tend to focus on the most common type, but I want you to know that these also occur. So the classic case is going to be a child of Ashkenazi Jewish descent who has an enlarged spleen on exam. There may be anemia and bruising from the bone marrow involvement. There may be joint pain and fractures. And remember that Gaucher's disease results from a deficiency of glucocerebrosidase and an accumulation of glucocerebroside. The next sphingolipid we're going to discuss is called sphingomyelin. Sphingomyelin is a ceramide molecule, as I've shown on the screen here, with a phosphate nitrogen head group. This molecule is broken down by an appropriately named enzyme called sphingomyelinase, and if you are deficient in this enzyme, you have a condition called Niemann-Pick disease. Niemann-Pick disease is autosomal recessive like most of the lysosomal storage diseases, and like Gaucher's disease, it is more common among the Ashkenazi Jewish population. Also like Gaucher's disease, it can result in splenomegaly, but what makes it different from Gaucher's disease is that neurologic deficits are the norm. In Gaucher's disease, they only occur in rare variants, not the most common type. In Niemann-Pick disease, neurologic deficits are much more common. There are multiple subtypes of the disease, and the severity can range from mild to very severe, and it can present anywhere from infancy to adulthood based on the type of disease that the child or the adult has. Niemann-Pick disease can result in hepatosplenomegaly just like Gaucher's disease, and because of the enlarged spleen, secondary thrombocytopenia can potentially develop and lead to bruising and bleeding. In addition, there is progressive neuroimpairment, so it will start slowly and worsen over time as the sphingolipids accumulate. And one of the classic ways for this to present is a child that was previously well but begins to lose motor skills that they had previously appeared to master. The pathology is large macrophages with lipids. They're called foam cells. This is a picture of one here. You can see them in the spleen and bone marrow. And you want to remember that macrophages are important in the pathology of this disease, just like they are in Gaucher's disease. And children born with severe forms of Niemann-Pick will die within 3 to 4 years. If you have a milder form, you can potentially live longer. There's an important physical exam finding in Niemann-Pick disease called a cherry red spot. This is a finding you see on fundoscopic exam when you look at the back of the eye. This is a picture of a cherry red spot. It actually happens because the back of the eye becomes pale in this area and it makes a bright red spot appear in the middle. Now, the most common reason this occurs, and the way you may actually see it clinically, is as a result of a stroke that causes central retinal artery occlusion. But you should never see this in children. If you see it in a child, then they are most likely describing Niemann-Pick disease or another lysosomal storage disease that we'll talk about in a minute called Tay-Sachs. Both of these lysosomal storage diseases result in the cherry red spot on physical exam. So the classic case of Niemann-Pick disease is a previously well, healthy child who starts to develop weakness and loses motor skills. There will be an enlarged liver or spleen on physical exam and a cherry red spot when you look in the back of the eye. Now, the cherry red spot can make you think of Tay-Sachs disease, but the liver and spleen are not part of Tay-Sachs disease. If you see hepatosplenomegaly, then they are probably talking about Niemann-Pick in a child who has a cherry red spot. And then remember that the deficiency here is the enzyme sphingomyelinase, and the accumulation is of sphingomyelin. The next sphingolipid is called galactocerebroside. This is a ceramide molecule with a galactose head group, as I have shown on the screen here. The enzyme that breaks down galactocerebroside is called galactocerebrosidase, and you should know that galactocerebroside is one of the major components of myelin. So if you cannot break down galactocerebroside and it builds up, you are going to have significant neuroimpairment because your myelin is going to be very abnormal. The condition that develops when you lack the enzyme galactocerebrosidase is called Krabbe's disease. Krabbe's disease is autosomal recessive like most of the lysosomal storage disorders. It usually presents very young, usually less than 6 months of age. Unlike some of the other disorders we've been discussing, there is no liver or spleen or bone marrow involvement in Krabbe's disease. There are only neurological symptoms. The dominant symptom complex will be progressive weakness in the baby. This means there will be developmental delay and eventually floppy limbs and loss of head control. On physical exam, there will be absent reflexes. Sometimes there can be what's called optic atrophy, where there's vision loss in the baby. Another unusual feature that sometimes develops in Krabbe's disease is fever without infection. And this is progressive and deadly. Usually the child dies in less than 2 years. If you Google this on YouTube, you can find some very sad videos of parents whose child appeared to be normal at birth and then developed Krabbe's and then slowly got weaker and weaker until the child died. Krabbe's disease is also sometimes called globoid cell leukodystrophy, and the reason for this name is because there are cells called globoid cells that you can see in biopsy specimens of nerve tissue. This is an example of a globoid cell on the screen here. They're globe-shaped. That's how they get their name. They often contain more than one nucleus, and they're the pathologic hallmark of Krabbe's disease. The next group of sphingolipids we're going to discuss are the gangliosides. The gangliosides are a family of sphingolipid molecules, and as you can imagine from the word ganglion being in their name, they're all important for nerve function. All of the gangliosides have ceramide molecules with a head group that contains a structure called NANA. NANA stands for N-acetylneuraminic acid. It's also sometimes called sialic acid. If you look at the structure on the screen here, you can see that there's a ceramide molecule connected to glucose, galactose, and galactose as we have seen before. But what makes this a ganglioside is the fact that a nanomolecule is connected to one of the sugar moieties. The names of gangliosides go by names like GM1 and GM2 and GM3, and this is a naming system for these molecules. The G stands for ganglioside, the M stands for the number of nanomolecules. Most of them are GM, and the M means a mono, meaning only one nanomolecule present. And then 1, 2, and 3 refers to the sugar sequence. So for example, this is the structure of GM2 on the screen here. It has a glucose, galactose, and galactose. Other sugar sequences have different numbers like GM1 and GM3. The reason gangliosides are important for this module is because defective metabolism of gangliosides can lead to Tay-Sachs disease. Tay-Sachs disease results from an enzyme deficiency of hexosaminidase A. This is an enzyme that breaks down the GM2 ganglioside. As a result, accumulation of GM2 gangliosides occurs in the nervous system, leading to Tay-Sachs disease. And like several of the other lysosomal storage diseases, Tay-Sachs disease is more common among people of Ashkenazi Jewish descent. Children with Tay-Sachs disease are born appearing normal, but by about 3 to 6 months of age, the babies display signs of the condition, and the dominant sign is progressive neurodegeneration. Remember, you need gangliosides for your neurons, and therefore neurodegeneration is the key feature of Tay-Sachs. There's the slow onset of weakness that will eventually progress to a vegetative state and death. These babies often display an exaggerated startle response, and their condition progresses until they have seizures, vision and hearing loss, and ultimately paralysis. And as I said before, usually death occurs before a few years of age. Much like Niemann-Pick, there is also a cherry red spot seen in Tay-Sachs disease, but in contrast with Niemann-Pick, there is no liver or spleen involvement in Tay-Sachs disease. It is purely a neuro condition. And a classic pathfinding is to see lysosomes with onion skinning. This is usually seen under electron microscopy, where you have cells heavily zoomed in, and you will see circles inside of the lysosomes that look like the skin of an onion. And you can Google this online or look in pathology textbooks, and you'll see examples of the onion skinning in Tay-Sachs. So the classic presentation to know for your boards is a very small baby, 3 to 6 months years of age, of Ashkenazi Jewish descent, with a developmental delay, an exaggerated startle response, and a cherry red spot on fundoscopic exam. And remember that Tay-Sachs is due to a deficiency of hexosaminidase A and accumulation of the GM2 ganglioside. A few slides ago, we talked about a molecule called galactocerebroside, which consisted of ceramide with a galactose head group. And we talked about how galactocerebroside accumulated in Krabbe's disease and how it was an important molecule for myelin. Well, if you add sulfuric acid to galactocerebroside, you get a structure called a sulfatide. This is an example of a sulfatide on the screen. It's similar to galactocerebroside except for the addition of a sulfuric acid moiety. And just like galactocerebroside was very important for myelin, so too are sulfatides. They are major components of myelin and nerve tissue. Sulfatides can be broken down by aryl sulfatase A, and if you are deficient in this enzyme, you will develop a condition called metachromatic leukodystrophy. And as we will see, the symptoms of metachromatic leukodystrophy are similar to Krabbe's because both involve abnormal metabolism of major components of myelin. Metachromatic leukodystrophy gets its name from the appearance of biopsy specimens under the microscope. The sulfatides take up color stains differently and create color patterns, and that's why it's called metachromatic. It's an autosomal recessive condition, just like most of the lysosomal storage diseases. The onset of metachromatic leukodystrophy in terms of symptoms can be anywhere from childhood to adulthood, depending on the subtype. And in fact, the most common type presents at about 2 years of age. And it's very helpful to remember this for board questions, because this is a way to distinguish it from Krabbe's disease. As I told you before, Krabbe's will usually present in an infant less than 6 months of age. Metachromatic leukodystrophy, on the other hand, will be a child about 2 years of age or slightly older. And remember, both of these conditions have similar symptoms because they both involve molecules that are important for myelin, so the age of onset can be very useful. The symptoms are purely neurologic. This will be a 2-year-old child or older, so the child should be walking, and there will be problems with gait, so there'll be ataxia and falls. There can be hypotonia, which can present as speech problems in a child that should be presenting at an age when they can learn to talk. Dementia can develop, and this usually progresses, and most children do not survive childhood. This slide is one of the most important slides in this module. It contains my algorithm for organizing the sphingolipidosis disorders in your mind. First of all, I recommend that you think about Fabry's disease and Gaucher's disease separately from the other lysosomal storage disorders, and that's because for most patients with Fabry's and Gaucher's disease, weakness is not a major component of the condition. Patients with Fabry's disease have hand and feet pain and decreased sweat and rash, and this triad is very unique, and when you see this, you should only think of Fabry's disease. Gaucher's patients present with an enlarged spleen, and they have anemia, and they can have fractures, and these three things together should make you think of Gaucher's disease. Another reason to think of Fabry's disease and Gaucher's disease together is because they both have enzyme replacement therapies that are available, and in addition, patients with these two lysosomal storage diseases can live well into adulthood. Some patients with Gaucher's disease even have a normal lifespan, and that makes them unique among the lysosomal storage diseases. I'll clear the screen here and I'll talk about the 4 sphingolipidoses that present with weakness as a major feature of the disorder. And in this case, the age of onset of the condition is very important. Krabbe's disease and Tay-Sachs disease are the 2 sphingolipidoses that will usually present as a baby. If it's a baby with progressive neurodysfunction and no cherry red spot, that is probably a child who has Krabbe's disease. Tay-Sachs disease, remember, presents as a baby. It does have a cherry red spot. The child is usually of Ashkenazi Jewish descent, and the cherry red spot can sometimes make you think of Niemann-Pick's disease, but in Tay-Sachs there is no splenomegaly, and that's how you can distinguish this disorder. We talked about metachromatic leukodystrophy on the last slide. Remember, it's usually a child that's 2 years old or older. This child should be walking, and therefore you will see ataxia and falls as a major feature, in addition to all the other neurological progressive symptoms that you can also see in Krabbe's. And then finally, there's Niemann-Pick disease. Remember that the age of onset of this condition is anywhere from childhood to adulthood. In a board question, it'll usually be an older child who loses a motor ability they previously had. There's liver and spleen enlargement, and there's also a cherry red spot in Niemann-Pick, just like in Tay-Sachs disease. And then finally, at the bottom left of the screen here are some key words for you to remember. Remember that all the structures that are abnormally metabolized in these disorders contain sphingosine and fatty acids, and they are all derivatives of ceramides. Many times on step 1 of the boards, they simply want you to know the type of molecules that are involved, so knowing these 3 keywords can be very helpful. Next, we're going to talk about some lysosomal storage disorders that do not involve sphingolipids. These storage disorders involve structures called glycosaminoglycans. Glycosaminoglycans used to be called mucopolysaccharides because they're found in mucus and they consist of polysaccharides, and many people still refer to them by this name. They are long polysaccharide chains, which means they're made up of sugar molecules of 6 carbons attached to oxygens and hydrogens. And in fact, all of the glycosaminoglycans have repeating disaccharide units. So there are 2 sugar molecules linked together, and then there are repeating sets of those 2 sugars linked together to build a big molecule called a glycosaminoglycan. And all of the glycosaminoglycans have 2 molecules as part of their disaccharide set. One of them is an amino sugar, and one is a uronic acid. If you look at the structure on the screen, I've shown the structure of chondroitin sulfate, which is a glycosaminoglycan. And you may know that this structure is very important for cartilage and ligaments and tendons. And it's got 2 sugar molecules linked together. This is one, and this is the second one right here. The second one here has a nitrogen group, so it is an amino sugar, and this group here is a form of a molecule called a uronic acid. They're linked together, and then repeating sets of these 2 go on and on and on to form a long structure of chondroitin sulfate. And I'll just point out here that this amino sugar on the right side of the screen here in chondroitin sulfate is called N-acetylglucosamine. And if that sounds familiar to you, that's because this same structure is found in peptidoglycan in bacterial cell walls. It's also found in many glycosaminoglycans inside the human body. The 2 glycosaminoglycans that are relevant for the lysosomal storage disorders we're going to talk about are heparan sulfate and dermatan sulfate. The word heparan sounds a lot like heparin, which you may know is an anticoagulant drug, and that's because the 2 molecules have very similar structures and in fact both function as an anticoagulant. Heparan sulfate and dermatan sulfate can be found on the surfaces of cells in the body, and as we will see, they will accumulate in 2 important lysosomal storage diseases. They both are made up of repeating disaccharide units, and you don't need to know the names of both disaccharides, but you should know that each of these 2 structures contains iduronate as one of their disaccharide molecules. And as we will see, iduronate is something that accumulates in 2 important lysosomal storage diseases. The two lysosomal storage disorders that involve glycosaminoglycans that we're going to discuss are Hurler's syndrome and Hunter's syndrome. And both of these disorders occur due to inability to break down heparan and dermatan sulfate. You can diagnose these by finding elevated mucopolysaccharides in the urine, and that should make sense to you because, as we just saw, heparan and dermatan sulfate are both examples of mucopolysaccharides. And in fact, both of these disorders are part of a class of very rare disorders called mucopolysaccharidosis disorders. Hurler's is called a type 1 mucopolysaccharidosis, Hunter's is a type 2, and there are a total of 7 types. Hurler syndrome is an autosomal recessive condition, just like many of the lysosomal storage diseases. It's caused by a deficiency of the enzyme alpha-L-iduronidase, and remember that iduronate is an important component of heparan and dermatan sulfate. And so when a child is born deficient in this enzyme, that leads to accumulation of heparan and dermatan sulfate. Symptoms usually appear within the first year of life. One of the most striking features are the facial abnormalities described as coarse facial features. If you Google Hurler syndrome, you will see pictures of children with this disorder, and the facial abnormalities are very striking. These children often have short stature and intellectual disability, and they also commonly develop hepatosplenomegaly from accumulation of heparan and dermatan sulfate in the liver and spleen. Children with Hurler syndrome have a characteristic set of X-ray findings called dysostosis multiplex. This includes an enlarged skull and abnormal ribs and spines. Dysostosis multiplex is very rare, and you don't need to know how to recognize it, but you should know that this is what it's called when you take X-rays of children who have Hurler's and examine the skull and the ribs and the spine. Another important and characteristic feature of Hurler syndrome is corneal clouding. Recall that the cornea is the layer of the eye that sits on top of the lens. It's at the front of the eye, and it becomes clouded in Hurler syndrome, and this is something that's easy to see on physical exam. This results from abnormal size and arrangement of collagen fibers in the cornea. In addition, these children have recurrent ear, sinus, and pulmonary infections, and that's because they have thick secretions because they have abnormal mucopolysaccharides. And then finally, these children can develop airway obstruction and sleep apnea, and that's because their tracheal cartilage tends to be abnormal. Hunter's syndrome is the other disorder involving glycosaminoglycans that we'll discuss in this module. Hunter's syndrome is unusual among lysosomal storage disorders because it is X-linked recessive. The enzyme that is deficient in Hunter syndrome is called iduronate 2-sulfatase, or IDS. Once again, it has that word iduronate in it, and if you know that iduronate is a component of heparan sulfate and dermatan sulfate, then it's easy to understand why dermatan sulfate and heparan sulfate accumulate in this disorder. The symptoms in the children with Hunter syndrome are similar to Hurler syndrome, except for a couple of exceptions. The onset is slightly later. These children tend to be 1 to 2 years of age when they express symptoms. Very importantly for board questions, there is no corneal clotting seen. So in a board question about Hunter's, corneal clotting will not be described. And then finally, a unique feature of the Hunter syndrome patients is that in some variants of the disorder, these children have behavioral problems. They can have learning difficulty and trouble sitting still that can mimic ADHD, and they can express aggressive behavior towards other children and even adults. So now we've talked about the sphingolipid disorders and the disorders of glycosaminoglycans, which are also called mucopolysaccharides. Now I'm going to talk about an example of a mucolipidosis disorder, and these disorders have combined features of the sphingolipid and mucopolysaccharide diseases. Basically, these disorders involve accumulation of both sphingolipids and glycosaminoglycans. That's why they're combined disorders. The disease we're going to talk about is called eye cell disease, which stands for inclusion cell disease, and it gets this name for inclusions that you can see on light microscopy of biopsies of people with this condition. And eye cell disease shares many features with Hurler syndrome. Its onset is in the first year of life. Some of the features are present at birth. There's growth failure and coarse facial features. There's hypotonia and motor delay. These children have frequent respiratory infections and clouded corneas, just like Hurler syndrome. They can have joint abnormalities and dysostosis multiplex seen on X-ray images. The reason they like to ask you about eye cell disease on step 1 of the boards is because it's a way to test your underlying knowledge of basic cell biology. What's interesting about eye cell disease is that the lysosomal enzymes are synthesized normally. The problem occurs in processing of those enzymes in the Golgi apparatus. Normally in the Golgi apparatus, mannose-6-phosphate is added to lysosomal proteins. This is the structure of mannose-6-phosphate on the top of the screen here to help you remember that it's important in the Golgi apparatus. When it gets added to lysosomal proteins, it directs those enzymes to the lysosome. What happens in eye cell disease is that mannose-6-phosphate does not get added to lysosome proteins. As a result, Those enzymes get secreted outside of the cell instead of going inside of the lysosome. Once you understand this cell biology, it's easy to understand the clinical findings. Patients who have eye cell disease have deficient intracellular enzyme levels when you measure the levels of lysosomal enzymes inside of white cells or fibroblasts. In addition, if you measure the enzyme levels of lysosomal enzymes in the plasma, which represents the extracellular space, you will find that those enzyme levels are elevated. So low levels inside of cells, high levels outside of cells. In addition, multiple enzymes are abnormal. This makes eye cell disease different from the other storage diseases we've been talking about, where it's a single enzyme that represents the problem. And then finally, in eye cell disease, intracellular inclusions are seen in white cells and fibroblasts, and that's why it's called inclusion cell disease. I'll finish this module with one slide on Pompe's disease. Pompe's disease is both a lysosomal storage disease and a glycogen storage disease. I talk about this in more detail in the module on glycogen. For our purposes here, I will just remind you that it results from a deficiency of acid alpha-glucosidase, which is also called lysosomal acid maltase. As a result, glycogen accumulates in lysosomes. That's why it's called a glycogen storage disease. The classic form presents in infancy with severe disease that often leads to death in infancy or childhood. And that concludes our module on the lysosomal storage diseases.